that we are going to do, that we are going to tell you now, okay? Because when you do a band, when you do some kind of adjustment, it's not that just that tooth that you are going to deal with. You have to understand what is going to happen to that tooth when you want to do something to avoid or to correct something that you generate in your treatment. That bend, that torque, that thing you're applying, it comes with a cost. It's not that isolated thing that you think, okay? You have some side effects that you need to anticipate also in order to speed up the mechanics. Because if you just think about what you want to do and don't think about the side effect may slow your treatment because you have to deal with that at some point, okay? And that's what we are going to do now, understanding this phase, aligning and leveling. And I decided not to deal with the wire sequence here because we know that wire sequence is very personal. I can just use a kind of wire sequence for my patient with a huge crowd, with a great crowding, or in cases with by protrusion, I choose a different wire sequence. And if you use that kind of prescription or self-ligating brackets, use your prescription. And I don't want to do that because it's very personal. So I'm going to skip that part. And I'm going to show you the problems that we have during this phase and the solutions that we can put, that we can apply to that treatment at that phase. Because the solutions are very important for us now. We dealt with the bonding at the beginning, and now we think that everything goes smoothly to a certain point, okay? But we need now to understand what to do. And the alignment and leveling of teeth using wire, starting with the wire sequence, starting with thinner ones from Itai alloys. You can use martensite, active martensite, active austenite. You have many possibilities. Passing through round steel wires to rectangular steel wires can present a huge variety of possible sequences that will be subject to demands of each case, meaning it's something that we can lose time here discussing this, and you may think that it's not something good for you. So for me, what is important? Wire sequence goes on, and then I reach the 018 stainless steel wire, okay? In my sequence, just for you to know, I go with the Itai wires at the beginning. It depends on the case, martensite, active martensite, or active austenite Itai wires. It depends on the crowding and many things that we are not going to discuss that because it's too boring. And now we reach the 018 SS wire, stainless steel wire. Why the 018? Because I prefer to start my bands with the 018. It's not that much stiff, and it's not that much difficult to deal as 016. So 018 is very good for me. And when I reach that, I usually ask for a panoramic X-ray, okay? Sometimes earlier than that, but at 018, I really want to do that because I see everything. I see angulations, I see the contact point, the contact between roots, I see the uprighting of the roots, if they are completely uprighted or not, or with increased angulation and root resorption and everything that is very important for us to control. Many things that are very important for us to control, to be in control, okay? So this is where I do the bands. The 018 stainless steel arch wire, this is where I usually start doing the bands. It doesn't mean that if I have to do a band with a rectangular arch wire, I don't do that. I do that, and I do that very often. But I prefer, if I have the opportunity, I prefer to start doing the correction here at the 018. So you can do the first order, second order bands in this position, in this part of the treatment, and we'll do the third order bands when we apply the rectangular arch wire, of course, okay? So now we have possibilities of doing the insets, the offsets, the Z-bands, the first order Z-bands, and everything that will help our patient to have a smooth treatment, a faster treatment, without the need of going back in our sequence, okay? As I told you before, I don't want to do that. I want to go forward. What I want to do is to have a smooth treatment, even though I have a chair time, more chair time for that. I need to apply the bends, I need to apply the torques, I need to apply the loops that I use very much. So this is something that I usually do. I understand the case, I do the planning, I anticipate the problems that I can anticipate. Sometimes I don't see that coming and I have to do the bends because I commit mistakes. Yes, I do every time. Guys, every time I do that. Every time I have to correct something that I didn't see before. And it's very, very common. The learning curve is steep for us in orthodontics. Even with 20-something years of orthodontic practice, I commit a lot of mistakes. It's very common. But what I consider that is fair to my patient is that I assume that mistake, I do what I have to do at that part of treatment without the need of going backwards and to elongate the treatment because of my mistakes. So I deal with the mistakes when I find them. And I have to find them very, very early in orthodontic treatment. So the 018, it allows me to do everything that I need to correct the problem. And I can either go on with the bands or loops that I'm using, or I can rebond after having it corrected. But consider that now I'm going forward in the arch wire sequence, not backwards. So I'm not losing time, or at least I'm losing little time here, beginning thinking about the end of treatment, okay? So let's see what we do. Let's think what we do when we do the first order bands, the second order bands, and on and on and on. First of all, the first order bands, as you know, we have, as you probably know, this is something that I do a lot, and I have workshops on that, and I know that people want to understand that. Why do I know that? Because many people ask me, Professor, what can I do in this situation using bands, using the loops, using the torques? And I know that you know, because you're here today with me, that you know that is important for your treatment. Because sometimes we feel that people say, no, it's not necessary to understand bands, to understand loops, to understand torque. You just have to choose the right prescription for that. That magic prescription will allow you to do your smooth treatment since the beginning to the end without the need of understanding nothing more than inserting another arch wire. It's a lie. It's not true. It's a lie. Unless you don't want to finish your case in a solid integrospan with beautiful inclination, with more stability. So if you don't want to do that, and I know you want to do that, you can just think about this easy thinking. I just want to run the sequence of arch wire and choose the right prescription. There is no right prescription. There's the hand of orthodontist, there's orthodontic planning, and there is managing the problems that we know that happens during treatment, because we don't treat just one kind of patient. Our patient, they have orthodontic problems, periodontal problems, they have abscences, they have inclinations that are very uncommon. So we need to deal with everything. So for that, we have to individualize our treatment. Believe me, when you do that, you will sleep, you put your head in your pillow and you sleep very easily. You don't think about, oh my gosh, how will I treat that patient tomorrow that comes to me because it has that huge inclination? In my prescription, as I see, because I'm treating for 5 years now, I see it won't cover all the situations because they are made for the average cases, okay? Even the class 2, the class 3 prescriptions, they are made for average cases. And now we have to deal with the individualization, okay? That's it. First order bands. I talk too much, I know that. I'm sorry for that. But I'm passionate for this. I love biomechanics, I love orthodontics, and I love teaching people how to deal with problems, for them to anticipate the problems and or correct the problems when they arise, because I know that people, and I see that when they come back to me and say, Professor, that thing you taught me was something that helped me a lot. My gosh, this is something that I love, because helping people is our nature as human beings. Try to help people is our nature as human being. And if I have a little bit more experience than you have, and if I deal with something now in my practice that helped me, helping you to do that is what I think is most important thing for me. Okay, so let's deal with the first order bands. First order bands are those made horizontally in the arch wires. So we have offsets, insets, canine eminence bands, toe ins, toe outs, first order Z bands. So we have many possibilities other than those, but those are the most common. Okay, in my workshops, I usually go through all those and the hands-on on those, and I see that many people don't deal with that. But when we start doing, when we practice, you will see that it's easy for you to do. So let's see how it goes here when we use, for example, first order Z band. When do I use first order Z band usually? I do this first order Z bands in those situations. For example, when I have thinner, when I have a discrepancy of size discrepancy of the lateral incisors, which are common, which are very common. We know that the last tooth of each group of teeth, they have this possibility of being more malformed. The shape is different, sometimes absence. When we see this in third molars, from the molars, second premolars, from the second premolars region, and lateral incisors concerning the incisors. So we see that's very common. So lateral incisors, they sometimes have this thinner, meaning buccal, palatally thinner. And when you do the leveling and alignment of those teeth, they go forward because the bases of those brackets, they don't anticipate this thinner crown. So sometimes they go like this, and we have to do this inset band for correcting this. Sometimes inset plus torque. But let's think just about the round wire in which we are now, and we can correct this using this inset band. So we do that, and we can correct. Sometimes we have to add a torque for that because it's in the right position, but we can see that the root is not the right position, and we add torque for that, okay? But we are dealing now with the round wires. We can do torque now. We can't do because we don't have the rectangular arch wire for that. So here is the torque, the inset. And I'm going to show you how I do and how I teach my students how to do. So first thing, let's do first the mesial band, meaning you go from the center midline, the midline, and you are going to do the band at some point of your arch. But think, the first band you're going to do is the mesial band, okay? Why is that? Can I start with the distal band? Of course you can. I'm just trying to put in your head how I deal with that and how I think the band and how I teach the band for my students. As we're having this class here, you are being my students today. I know many of you know how to do that, but I know that many of you don't know how to do that. So I'm going to explain like anyone, everyone don't know how to do that, okay? So in this case, the first band is a mesial band, and I'm going to start pressing or pushing the first the part mesial to the pliers. So I did my mark here. I grab my wire here with my pliers. In this case, I always use a 139. You can call it Jarabak plier or bird beak plier, same thing. And I use this with this a very thin point of the conic point of the plier, because this is how I do very discrete band, okay? Very discrete bands. So I use the pliers for that. One important thing is to grab firmly the arch wire, and the arch wire, it has to be horizontal, and your pliers going to be perpendicular to the horizontal. Grab it firmly, avoiding to rotate because you're using now a round arch wire. So you now grab the position in what you want here is to do an inset band in this lateral incisor. As you can see, this is the midline, and I'm applying here the bend, okay? So I put the plier in position, that thing that I told you is important, very firmly, and now I'm gonna push it inwards. Why inwards, Kleber? Because the first bend you want to do is inwards, because you want to do an inset. So as you can imagine, the first bend is going inwards, okay? Inwards meaning you're going to push your lateral incisor inwards. So now I'm gonna do this, pressing with my thumb here, inwards, not a very great pressure. You don't need that because you're dealing with 018 arch wire. And now we go inwards. Then without removing the plier from its position, keeping the plier in its position, now you change your finger to the distal portion of the plier, okay? And now, as you know, you first went inward, you have to go outwards now. You have to go back to the outline of the arch wire. You have to go back to the position of the wire without disturbing the angulation or anything. Doing this now, going outwards. Let's see how it goes in the video. First, mesial in and distal out. Look, didn't remove the plier's position. And one important thing here, try to do the second bend. When you are doing the second bend, try to return to the outline of the arch wire, meaning to continue the outline, continue the form of the arch wire, okay? So now we have this possibility of returning to the original outline of the arch wire. So first mesial in, distal out. And the important thing here is the form of your arch wire. So now we want to go back because we have this inward position of the arch wire. In that part you did the bend. So we want to go first out. Remember, mesial out, distal in. So the trick here to understand always what you have to do is to start your bend. This is the second bend of the first order bend. You have to grab firmly the arch wire and you go mesial first and distal after that. So what we want to do mesial is go out. It's going out, out, mesial now, and in distal, okay? Without removing the plier of its position. Okay, good. This is a first order Z bend. What is important about this first order Z bend? This is important. The outline of the arch wire, it remains the same. It's necessary to preserve the contour of the arch wire. And now we have just this bend here, inwards. But, I'm sorry, as you can see, it is the same line of the contour of the arch wire, just a little bit inwards. And this is important because this is the bend you want to make. Let's see the out bend. Let's see how we do the opposite of that. And now I want to do an offset bend. Let's see how it goes. Same thinking. I grab the wire and now I want to go out first. Remember, mesial to the plier, out first, then in without removing the plier. Again, think about the contour of the arch wire. Again, we go out mesial and in distal. Because why can't I do different from that? Of course you can. I'm just giving you a tip how to think always what you want of the bend. In this case, you want to go first out and then in. Out is the first bend. Okay, let's see how it goes again, just one more time. So I grab my wire with the plier firmly, and I go first mesial to the plier out, which is the first bend that I want to do, because it's out bend. This is an offset band. And then we go in, okay? And now we want to return to the contour because we have this band outside. I don't want to apply that band to all those teeth, just to one tooth. And now I'm going, because I'm out, I'm going in. Again, mesial to the plier, I do the first pressure. So I go mesial, inwards, and I go without removing the plier of its position, I'm going outwards. And you're going to receive those videos, you're going to practice, and you're going to do it perfectly. As you can see here, we have to have that same thing. The contour is preserved. The outline of the arch wire is preserved. You just have that specific band in that specific position, okay? Good. And before inserting the arch wire inside the slot, you need to confirm what you are having as an outcome. For example, here, I want to go outwards with this band here, with this tooth here. So I put in the position the arch wire and the neighboring tooth. I confirm the passivity of the arch in relation to my dental arch, okay? The arch wire in relation to my dental arch. I always do that. And I see that just in this point here, I'm going to have the wire outside the slot, which is what I want, which is what I need, which is what I planned for. Certo? Okay. I'm speaking Portuguese now. Certo is okay. Let's move on. And now I have another band that is very common that I use in my practice, is the first order Z band. The first order Z band is made to rotate, to derotate actually one tooth that is rotated. And I apply just one tooth, okay? The thinking here is the same. Let's think about a position in which we have to go with the mesial part of the lateral incisor outwards and the distal part of the lateral incisor inwards, meaning this lateral incisor is rotated with its mesial position inwards and this distal position outwards. And I want to do the opposite now. Of course, I want to go outwards mesial and inwards distal because it's rotated. And to do the correction, I have to go in the opposite direction of the malpositioned tooth. So I want to go out, distal, and in mesial, okay? In this position, I'm going to go to produce a band with the mesial part of the band out and the distal part of the band in, okay? And this is something that we have to do very often in our practice. The band here that you're going to see is actually the opposite of that. Let's think about what we do when we have a outward position of the mesial part of the lateral incisor and an inward position of the mesial distal part of this lateral incisor. See how it goes. Let me just put a note here. So what we have here is this. Okay, we have the lateral incisor like this, comparing to the central incisor. So what we are going to do here, we're going to do a band that goes this way, pushing this way, the mesial part of the lateral incisor, and this way, the distal part of the lateral incisor. So the first band that I want to do here is a mesial band, and the mesial is inward band. So the first band we did is the same one that we did before. Pressing in the distal portion, in the mesial portion of the wire inwards. So we made this band here. And now I'm going outwards. But in this situation, I'm going outwards. Let me remove it here. I'm going outwards, keeping an angulation of 20 to 30 degrees. Let's see how it works. So the second band here is like this. Let me just, okay. Let me just remove it here. Okay. Now we're done. And the first bend we're going to do, the second bend we're going to do now is inwards, because we did that bend outwards, and we did that with an angulation. Different from the first order Z bend, a regular first order Z bend, in an inset bend that we showed before. We don't have to have it like horizontal. We don't have to have that part, that active part of the bend at the same outline, just inwards in comparison to the outline of the arch wire. We have to have, and we need to have an angulation here. Okay, then I'm going to show it to you. So we did the first bend as the inset, same thing, mesial in. When we did the distal out, we did a distal out with more angulation, because we want that part to be angulated in comparison to the contour of the arch wire, being the mesial in and the distal out. So now I'm gonna go inwards again, because I'm out. You remember? Because I'm out here. So now, in order to go back to the position that we want, we go like this. This is what I want here. I want to go inwards in this position, but going inwards and then going outwards again as the same bend here. So we have two equal bends. Remember, we did inwards and outwards. Here's the same now. Inwards mesial, outwards distal. Why is that? Because they are the same bend, but you just put an angulation in the middle of the bend, okay? Let's see how it goes. Okay, and now we have the outward bends, okay? The outward bend. And now we go again to the contour of the arch wire. What is important here? The most important thing in this situation is that you don't disturb the contour of the arch wire. Meaning, if you go with a line, you see that the mesial and the distal portion of that bend, they are in line. What we have here is the mesial out and the distal in. The mesial out and the distal in, because that lateral incisor, the position that it has is mesial in, mesial out, here's the mesial out, and distal in. So I want to go the opposite here. Mesial, I want to go in to push it inwards, and distal to push it outwards, to pull it outwards, okay? So I'm correcting that bad positioning of the lateral incisor doing this bend, okay? If you do that, what are you going to produce? If you do that, if you don't pay enough attention to the outline of the arch wire, the contour of the arch wire, you're going to produce two out bends, two offset bends, one here and the other one here. You're not going to correct the lateral incisor, because you're pushing the mesial, the distal of the central incisor outwards also. So you're not going to correct it. In this situation, this is bad for you. So you have always to check if you are preserving the contour of the arch wire, okay? Let's see how it goes with the bend. As you can see here, this is a case treated in one of our post-graduation program courses. In this case, you have the mesial of the central incisor inwards and the distal outwards. So the bend is doing the opposite. The bend is pushing here, is pulling here outwards, and pushing here inwards. In just 1 month, as you can see, we have it corrected. In 1 month, just in this case, what I did was to use a rectangular TMA arch wire, because when we saw this problem, patient was already with a rectangular stainless steel inserted in the brackets. So what we did, we go backwards just 1 month with a rectangular TMA arch wire, because it's not that stiff. It allows for a better correction, because you don't have to put much force for that. It's quite the opposite. We have to control the force. So in this case, I needed to preserve the torque that we had here, as we can do. This is what we can do using TMA. We cannot do that using night tie wires. So I use for that a TMA, and after that having corrected the positioning of this specific tooth, I ran the sequence of arch wire to a rectangular stainless steel 1925. So I didn't go back in my sequence. I went forward in my sequence. I just corrected during the sequence of arch wires. Can you imagine what we have done? What if we didn't know how to do the bends? We had to do what? To put the disc bracket more mesial and to go with a very thin arch wire here to correct the positioning. And for that, we need to go backwards in our sequence. So we would have this treatment delayed in its finishing if we have done that. Okay, this is what I think. And this is another important thing here. Remember, to make it more accurate, the bend is more accurate, to make the bend more effective, you need to use stainless steel ligatures for that. Don't use elastic bands for that, they won't work, okay? You have to do this. 1 month, corrected, go forward. Another tip that I give to you is to use, when you use, for example, in the lower arch wire, I don't use that much in the lower arch wire because of the interbracket distance. It's very difficult to correct just using this band. And sometimes I use a loop for that. But this band, sometimes it works. Sometimes it works. You don't have to do much of rotation, of the rotation of that tooth. It works, okay? But it's something important for you to understand that when you use round wires for that, they can slip, they can go out of the position. So you do the bend and you do the force and you do this ligature and it goes to the more easy position. It goes like slipping for one side or the other side. In order to avoid in this, we use stops, round wire stops, very close to brackets in order to avoid the rotation of the arch wire. So we do the bend, we mark the position, then we go with the stops, the round wire stops, and we crimple, we squeeze that stops in that position to avoid the rotation. So we are doing something more effective to the arch wire, okay? And now we use the stainless steel ligatures for that. And another thing that's important is to provide this space here, and for that we usually use IPR with Sound Blast, or we can use discs, you can use it wherever you want, but in this position, when they are crowded, I prefer to use those how can I send strips, okay, that I use for doing this kind of IPR, okay? Those strips, because you manually can contour in a more accurate position, in a more accurate way, okay? In order to do that, you do this with very much care, okay? So here we do, we start tying the ligature to the rotated tooth. As you can see, it goes out here. When we go inwards here, we are applying this inward force and it goes outward in this other position, okay? And again, we have the need to do this IPR and we can have the correction after a while. So as you can see, now I changed, which I usually do, I changed for a loop here because I have more wire in between those two brackets, allowing me to do it more softly. So this is something that I usually do, but it's me. You can correct that using the Z-band, okay? Canine eminence band. The canine eminence band is almost the same thing that I use when I do the offset band, but I don't need to go inwards again because usually you just want to correct the mesial portion of the canine here. As I showed you before, when we use the concept of putting the bracket more mesial, you usually avoid the need for doing this, okay? Usually avoid the need for doing this. But if you have to, you can use the canine eminence band for that. So I showed you before, I usually have this difference between the thickness of lateral incisor and canine, and when we put in the center of the canine, it usually pushes this tooth inwards and the lateral incisor outwards. So generating this kind of step between those two teeth. So in this case, what can we do to avoid that? We can position our bracket a little bit more mesial. So as you can see, when it goes a little bit more mesial, it goes to a thinner position of the canine, and now you can adjust it when you put the arch wire inside the slot. So we have that force that will tend to align those teeth. Yes, you can do that since the beginning. You can do that without, if you notice that there is this misalignment between looking from above between lateral incisor and canine, you can do the rebonding for doing that. As I told you before, I don't like it very much, but it's possible, and then we correct that. So what do I do when I notice that? Look at this very, very interesting example. Here in this position, I managed to put the position that I like to, which is a little bit more mesial. So putting in that position, I have a good position of alignment of the tips of those two teeth, okay? So comparing to the other side, the opposite side, in which I put in the center of the canine, what happened? It goes inward, it went inward, and the lateral incisor outwards. Now I have this misalignment between those two teeth. What do I need to do now? I could have done the rebonding, but I don't like to do that. I went to my beautiful eminence canine band, canine eminence band. I did this, okay? And doing that with the rectangular arch wire, I didn't change the rectangular arch wire, I have that corrected. So now it's everything okay. And again, that's what I consider very, very effective treatment, not needing to go backwards. So sometimes the rotation is that much big that just one eminence band couldn't help. So this is another solution for that. Sometimes it works. As you can see here, I'm just using this offset band, not to put inside the slot, but just to free the slot to do the rotation. What I did here, in this case, I repositioned the bracket more mesial, and I felt that was too much force for doing a canine eminence band here. So what did I do? I used for that this power chain. And this band here is just to avoid the contact between the canine bracket and the wire when it was being rotated. So in this case, this band here is not to correct the canine. It's just to avoid the contact. And what's correcting the canine here is the self-rotation of this canine generated by this power chain. Again, doing the IPR in mesial and distal portion of this tooth or those two teeth, okay? So as you can see, in just 1 month, almost corrected, and then we went on and we have in 2 months the correction of those rotated canines. People say for me, well, in this case, I would prefer to finish treatment and use aligners. So, but you know that aligners are not very effective to do in the rotation, especially in canines, because of the form, the anatomy of the canine. So in this case, you would have to do that in a very, very large sequence of aligners to do that. We know that in canine, we can expect those 2 degrees that some companies give to us from one to the other. So if we have here, for example, 20 degrees of rotation, we have 10 aligners for that. Could you do that in 2 months? Of course not. So think what is best for your patient, what can benefit your patient most. In this case, of course, the treatment could have finished faster and faster using this solution here, okay? In 2 months, we have it corrected. So as you can see, 1 month, correction is going on. In 2 months, you have it completely corrected. Now you can put another arch wire here with bands, with passive bands, just to keep the canine in position, okay? Passive bands means that when you have to do a band, that when you insert the wire inside the slot, it won't disturb the position of the slot and the teeth or tooth itself, okay? So you need to understand what your wire is doing to the teeth that you are going to correct, or the tooth, okay? So if you're just correcting one tooth. So in this case, 1 month, she went back to the office, and I did again the same thing, and with 2 months, we have this correction here. Okay, So now we can just finish our treatment having the correction done. Another thing that we use a lot, now we're going to the second order Z bands, second order bands, intrusion or extrusion bands. In second order bands, they are made in the vertical direction of the arch wires. So we have intrusion bands, extrusion bands, we can call step up, step down, or we can call intrusion or extrusion bands. And what I use very, very commonly, the second order Z band. Okay, let's start with the second order Z band that I consider very important for us in many situations of our treatment daily practice. Okay, so the aim here is to initially make a band. In this case, what I want to do, let me show it to you again here. So in this case, what I have is a lateral incisor that has this inclination, this angulation, I'm sorry. Has this angulation, okay? What I need to do here is this and this, okay? So the first band I want to do here is a band that pushes the mesial part of the incisor upwards, okay? And the distal part of the incisors, this incisor inwards, okay? So in this case, the first band that I need to do is upward. I go upward with this band. So let's see. I'm going up. What happened here? I don't know. It's stuck. Why? Yes. It goes up. Again, mesial, your finger in the mesial, and we press upwards, okay? Upwards in the mesial. So what's going to happen? When you do that, you have now one position, and the distal position is going to be up. So now we have the first band, and the second band, it goes downwards, okay? Without removing the plier of its position, it's going downward. But you have to remember that a Z band, it's not a horizontal band. It's an angulated band. So the second band, without removing the plier from its position, continue to hold it firmly. Again, if you're doing round wires, don't let the wire rotate. It's made by pressing downwards. Remember that the direction must be perpendicular to the plane of the arch. Okay, of course, because you don't want to make a bend inwards. You want to make a bend downwards, okay? With the thumb or the index finger, you do that, okay? So you press it downwards. In this case, now we have this band, angulated band, and now we have to do the same thing now in the distal portion of the wire that you have marked. So now we go upwards, and then we go downwards. Same thinking, mesial up, distal down, without removing. Now we have this band that is going to push in the mesial part of the bracket upwards here, and the distal part downward here. As can you see here? So now, if you have this and you need to check if you didn't disturb this line of the arch, because if you did that, you're going to have two bands, to downward, to step up or to step down bands. So take care, okay? You just need to have this, okay? So now I'm going to, let's see if the next, yes, let me show it here to you. So first, mesial up, distal down, keeping it angulated. Then you go distal up and mesial up and distal down. Let's see it again. So let's see it again. Finger mesial to the mark up. Without removing the plier, we go distal to the plier down. And now we have the angulated portion of the active band. Now we go mesial up and distal to the plier down, okay? And now we need to check if everything is in line. So now me just remove this ugly drawing here. Okay, erasure, okay. So as you can see here, what I'm doing is checking in the mouth if my band is going to do what I want it to do. So if you put it here and you see in the neighboring teeth, if they are in the same position, the same line, just in this portion here, we have the angulation, it is okay. Now we're going to have the band that you want to have. So the first band that you need to produce, you need to make, is a very slight band. You don't need to do those huge bands for that, okay? So you have to do that, increasing the band in the next visit of your patient. But the first band, you don't have to do that much. And you're going to learn how to do this, I promise you. So go first of all, understanding that the band is have to be slight and put it in a position and seeing if it's too much force or not. How much is that force? No, you know, it depends on the wire, it depends on the bracket that you are using. For example, here we have the sapphire bracket, which is not that solid enough to have a huge band. So we have to understand all those things and need to understand if they're active or not. Because if you put the wire inside and you don't have any force made, any force exerted to insert the wire inside the slot, it's not going to apply any force at all. So you have to do this, but you don't do have that magnitude of bend that when you put inside the slot, your patient cries. It's not that you want. It's not that you need to have. Okay. So in this case, we applied the force, and in 1 month we had it correct. In this case, I wanted to close the space because this patient has this size discrepancy, and he was a former student of ours in our post-graduation program, and he told me, "Professor, I don't want to have veneer in my teeth, in my tooth, and just move it, let's close the space with a little bit of angulation." And he wanted to do that, and that was what we did. So let me give you another example in which we do that often in the situation when we see that there's a contact between the roots of two incisors, for example, or any teeth that have this contact. We can apply this band for that, because we know that when we change the angulation of the crown in one position, we change the angulation of the root in the opposite position. So in this case, this is the band that we used. It is a distal in, mesial, distal down, mesial up, in order to rotate, to angulate that tooth. And after that, we can correct the position of the bracket, but now we don't need to go in the sequence, to step down in our sequence of arch wire, unless you have other things to correct. So sometimes you have. For here, for example, we had the vertical position of the central incisor, so we went back to correct that, okay? So this is what we do, and the correction that we make is very interesting. As you can see here, you have this before and after the band. Look at this. In 3 months, we managed to correct this position here, okay? This is a picture that a student of mine gave me, saying, "Professor, you were right. Look at what I did." And I asked him to show this. Look what I did, because I didn't check the outline of the arch wire. I didn't check the contour of the arch wire. So what he did here were two different bands from what he wanted. He wanted one Z band, but he did actually 2 step down bands, because he didn't check the horizontal position of these bands, okay? And this is not a situation in which we do that. For example, I work in this clinic in which we have 2 implantologists, and sometimes we have to do that. We have to open space, not just in between the crowns, but also between the roots, in order to secure space for inserting the implant. So in this case, we opted to do the opening in between the premolars, and I'm going to show you why I do that later on in this class. And we need to have 1.5 millimeters least between the root and the implant. So sometimes for that we need to do this diversion of the roots, and for that I usually use the Z-band, 2 Z-bands for that. Okay, and now we have a very good space to do this this positioning of the implant. And as you can see here, we managed to create a very good bone volume here, just positioning the premolars forward and backwards, opening the space in between them, allowing the implants to be inserted without the need of doing the graft first. Okay. Another situation is when we use these bands. When we use these bands, for example, when we have the need of doing the diversion in between lateral and canine, which is very common when you do a 3-piece osteotomy in an expansion case. In patients like this, for example, it was planned to do the expansion of the maxilla, a 3-piece osteotomy, and for that we have to secure space, to provide the space for doing the osteotomy in that position. So this is another situation in which we use this kind of Z-band. This is to do the conversion of the lateral incisor related to the central, and diversion related to the canine. Okay, so this is what we want, because this is where the osteotomy is made. As you can see here, a practical use of the lateral incisor convergence band, Z-band. Okay, before and after. Okay. And here, for finishing this first part of our lecture, because I know that you must be very tired now, and you go take a coffee, and we are going to finish in a little, some minutes. Just ask you some minutes to finish this before we start the second part. So this is intrusion or extrusion band. We know that when we do in round wires intrusion or extrusion movements, and we apply that force outside the center of resistance of that teeth, that group of teeth, or that specific tooth, we will generate not just the intrusion that we want, but we will also generate another kind of movement, which is a rotation. Why is that? Because the force is being applied outside the center of resistance, meaning we will generate also a moment. In this moment, we have to counteract in order to avoid the inclination being intrusion will be a buccal inclination of the crown, extrusion, it will be a lingual inclination of the crown. So in this case, if we don't want to have as a result, as an outcome of this movement, if you don't want to have, and you usually don't want it, especially in unitary movements, we don't want to have this inclination. What do? We can do using rectangular arch wires another moment to counteract the tendency of inclination, which is generated by the moment of the force of intrusion. So here we have the moment, the intrusion vector, meaning I have here the line of action of the force far from the center of resistance. So this force is going to generate out of the movement of intrusion, is going to generate a moment. In this case, a counterclockwise moment. So for avoiding this, I need to have a clockwise moment, which with using rectangular arch wire, I can do by inserting a torque. So in this case, what I can do here is to apply, a torque here, that will generate a counterclockwise moment that tends to cancel the moment generated by the force. So now we have a more true intrusion of this teeth, or this tooth, in this case, eccentric incisor. So we can do that using this concept of torque plus intrusion, okay? It's not that easy to do. Sometimes you have to deal with other situations, but it's something that you can have. Why is not that easy to do? Because you have to apply the torque here and the vertical bend here at the same point, so sometimes not that easy. So what I advise to you is to first do the torque and then do the bend, okay? If you want to do that, first the torque and then you can do the bend. So in rectangular arch wire, we have this kind of problem. So in this case, the vertical component, it has to be the vertical component that is going to generate the moment. If we don't want the moment to occur, if we want that, we don't want that outcome during the intrusion or extrusion with angulation of the crown, we need to anticipate that and use for that. If you are using rectangular arch wires, we need to use counter torque. Counter torque meaning the torque is going to be in direction of avoiding the movement, the inclination that you are having. Okay? So this is what we have to be aware all the time in order to achieve this beautiful intercuspation that we need to have this good settlement, this good intercuspation that we seek for. This is what I want in my practice. This is what I want with my patients, to have this kind of intercuspation. So when I do this, when I get this quality of intercuspation of those teeth, I'm sure, of course, I cannot say that I'm completely sure, but I'm almost certain that with time, it will be kept. With time, we will keep this kind of intercuspation. So here we have the possibility of doing this intercuspation using bands for that. Okay, using bands for that. At each point, every point of our treatment, we have to stop the treatment and think about how we are going to finish it. And one of the things that I pay attention is how is it going with the marginal ridges? Are they even or not? So beginning with the 018 stainless steel arch wire, I start doing the vertical steps, meaning intrusion or extrusion. As you can see here in this situation, this example, I try to put the bracket. In this case here, in this first premolar, lower premolar, I put the bracket more apical in relation to the other one because I wanted to compensate the height of the cusp. As you can see, we have here a much higher cusp in this first premolar comparing to the second premolar. So I was trying to anticipate this problem, putting in a more lower position, comparing to the other one. But as you can see here, it wasn't enough. It wasn't enough because I have this huge difference between the marginal ridges and the height of the cusp in between the first and second premolar. So now we have this difference, this step between the second and first premolar. As you can see, we have errors that are incorporated in our technique. Those errors are incorporated in our practice, not because of we are always committing errors. We are always giving the same mistakes to the patient. No, it's not. Sometimes we have this extremes of position, extremes of shape, extremes of many things that we don't manage to do everything correctly. So when this thing happens, we need to anticipate it. We need to understand the problem, and now we deal with the problem. How do we do that? We have two options here. We can either do the rebonding, which people love to do and I hate to do, or to do the bends, which I love to do and most people hate. Why is that? Because when you do that, you're going forward. That's always what I say. When you do that, you are not stopping your mechanics, you're not stopping your sequence of arch wires, you are just going forward, using for that the right tool to correct the problem. In this case, a vertical band. In this case, which tooth is wrong? This is the tooth that is wrong because of the wrong shape, because of the different shape. And in this case, this is the band that I'm going to do. So I'm just checking the margins, the gingival margins are not even. The marginal ridges are not even, and for that I have to do a step-up band. In this band, the step-up band or extrusion band, as we see here, is made to force this. I'm sorry, let's go backwards here. Here. Okay, yes. And this step-up band here, this extrusion band will deal with the vertical component here that it was wrong. So as you can see, this is the second band. This is the second time I did the band. As you can see, this is a rectangular arch wire. If I did this as a first band, it wouldn't get inside the slot at all. So this is the second band. So in the second visit of the patient, I increased the band, and for that, I used the same point, the same position, just to increase the band. Let's just me see something here. There's someone with the sound open. Yes, now it's okay. Okay, and this is a step band. This is another situation in which we have to understand that the problems that is generated because of the difference in the shape of tooth, in the shape of teeth. In this case, second upper premolar. The second upper premolar is tricky also because of its shape. Most of the time, it has a shorter clinical crown compared to the first molar and compared to the first premolar. So the second premolar sometimes gives that to us. This tricky situation. How can we deal with that? Because if I'm seeking the center of the crown to do the positioning of the bracket, in this case, I put in the right center of the bracket. What's going to happen? We will generate vertical errors because of the difference between the shapes. So it's very common in second premolar. It's very common. So what can we do for that? Not much, because sometimes we cannot go up. We cannot go like very close to the gingival margin. We can't go with the bracket to that close of the gingival margin because we can have problems with the periodontal structure. We can have problems with the gingiva. So in this case, sometimes we accept the error, we accept that we are going to have bands to do, or sometimes we don't even put the bracket in position in the beginning. So we wait till we reach a round stainless steel wire in order to do a passive band to keep the bracket in position. This is another way to see this. This is another way to do this. So in this case, when you put the bracket in the center of the crown, meaning the correct position, the position that we always seek for, we will generate this error not because of us, but because of the shape of the tooth. In this case, it will intrude this tooth or both teeth, if it is the case. And we will have these situations. It's very common because of the crown length, the height, crown height. So sometimes we have a shorter height and we aim the center of the crown and we put the bracket, we manage to put the bracket in the center of the crown. And as a result of that, we are going to have this error, this vertical mistake, this vertical error. So sometimes we have to do that. And in the end, at the end of the treatment, at the refinement phase, we will deal with this kind of problem. And for that, it won't apply a intercuspation elastics. Why not? Because the arch is rigid. We are using a stiff arch wire here. So we can just use for that intercuspation elastic. It won't work at all. So intercuspation elastics may be used if you remove the arch and use the intercuspation elastic, but you will have side effects that may be worse than doing the bands because you are going to have this extrusion, this uncontrolled extrusion with inclination of the crown toward palatal. So it's better for you to control everything. For that, we use bands. For that, we love to use bands. I think at the end of our class here, we are going to love bands also, because I'm so passionate about bands that I'm trying to pass it to you now. So bands, they are intelligent tools because they are extremely individualized. You can do whatever you want with the bands. You can't do whatever you want just rebonding brackets. Sometimes rebond is not the answer. Most of the time, rebonding is not the answer. So in this case, what can we do? I'm sorry. Would you rebond this bracket higher, like in the gingiva, for having the extrusion vector that you want? Of course not. Of course not. What do we do here? We deal with bands, and we have to understand the band, the outcomes of the band, and the side effects that they apply. So this is what we need to understand. In this case, the marginal ridges are uneven, and for that, what do? We apply an extrusion band. Remembering always then, when we do vertical components outside the center of resistance, meaning the bracket almost in all situations is out of the line of the center of resistance, unless it's very buccally inclined, but it's not common. So we will apply a vertical component, extrusive or intrusive, and we will always generate a moment because of that, because we don't have the line of action of the force applied in the direction of the center of resistance. So we are going to have the intrusion that we want plus the moment that sometimes we don't want. In this case, for example, when we are doing the extrusion, if you don't pay enough attention and do just the extrusion band, you will have what you want with round wires. You will have what you want, what you are aiming for, you're aiming at, but you still are not managing to control the lingual, the buccal inclination of the crown. So for that, if you're using round wires, you need to use another band, as we are going to see in some instances ahead. So now we have the uneven marginal ridges, and we are using, to correct that, an extrusive step. When you do that, this is what I always say. If you want to be a good orthodontist, I think one of the magics of this, one of the tricks of this, is to think forward. What I'm doing here, I'm doing that for that purpose. This is going what this is what we are going, or I am going to have at the end of treatment. Okay, but when I do that, is there a side effect in other teeth that are part of the anchorage for that movement? If there is, you need to cancel that side effect if it's not wanted. In this case, for example, what I'm doing here, I'm applying a vertical component, I'm applying a vertical force to extrude the premolar, but I know that as a side effect to the neighboring premolar and to the molar, it will have a opposite vector, meaning intrusive vector. If we have this nice intercuspation here, we want to keep it. And for that, we can use vertical elastics. We can use triangular elastics. And the triangular elastics I use for that are mainly 1/8 heavy elastics. 1/8 heavy elastics. It provides a force in this shape here, this triangle. It will apply a force that is not too much, because most of the time patients keep the mouth closed. So it will apply a good force for that. Kleber, is not too much. If you want to apply less force, maybe you will not control the vertical component. So I most always use these vertical elastics. So this is what we want without side effects to the neighboring teeth. Here we have trying to do the intercuspation. So the intercuspation was blocked because it touched here, and we have the stiffness of the round wire here, right? The round stainless steel wire. And if I wanted to change that, what can we do? Yes, we can use a braided arch, but with bands. A braided arch wire with bands, good. I don't think a braided arch wire, it delivers what it promises. You know why? Because I think they don't have the stiffness needed to control the torque, and they are not soft enough to allow the extrusion. So I don't use that much. I really like to use stainless steel for that. And if not, if I'm at the end of the intercruspation, I can just remove the wire from the posterior region and just use the elastics. But it has to be very close, very close. One arch to the other one arch to another. We have to have this proximity between the teeth, in order to use this kind of thinking, okay? And here, the extrusion band, and with elastics all the time, elastics, posterior, anterior elastics, and here we have the outcome. So for that, the extrusion band was used, okay? Another example here, as you can see, this case, we needed to do the intrusion band in molars and extrusion band in premolars, and for that, at this part of the treatment. As you can see here, guys, my friends, you don't have here a bad position of the bands and the bracts. It's centered as it has to be, as it's supposed to be. But what happens here? It's the difference. It's the difference between shapes. So we are not perfect in our positioning. Of course we are not. But even when we do a very good job doing the positioning, sometimes you have to do the bands. Because sometimes people say, oh, because if you position well those brackets, if everything goes well, you don't need to do bands. It's a lie. It's a lie, because we are not dealing with always with the medium cases. We are dealing with extremes. We have sometimes wider, we have sometimes taller crowns, we have sometimes wider crowns, we have many differences that we can control. And this is the situation in which we need to understand the bands, okay? So here, another situation, as you can see, we have many bands, band here, a band here, same thing here in the molar. And I consider that after 22 years of clinical practice, I managed to do the bonding in a good manner. But most of the time in my office, I need to do the bands. I need to do the adjustments, okay? Just put it here, sorry. Okay. Well, this is very common. The situation which I think someone asked me before, the second molar. The second molar is a difficult tooth to manage. Why is that? Because sometimes we put in a position, and if I had to go back here and the 6 keys of occlusion, I don't see much of my second molar patients with that positive inclination. Positive angulation, sorry. I see the opposite. I see with negative angulation, meaning the crown is backward, the crown is backward position. And when I go with my wire and try to do the right positioning, the standardized position with a positive angulation, sometimes I extrude that tooth. Sometimes I extrude those teeth. And I will do something very bad for occlusion because everything was very good before, but then I did the leveling and aligning of the second molar, and now I have very bad intercruspation because of extrusion of the molar. And if I don't pay attention, and if I don't manage to do that now, I may end up with a situation in which I can't control the extrusion. I can control the intercruspation. So most of the time in my second molar, I have to pay a lot of attention to that, to avoid that. But when it happens, what can I do to control? What can I do to correct that positioning? Intrusion bands are good, but most of the time I use intrusion loops for that, okay? But I'm gonna show you now the intrusion band, which is very easy to do. So when I do the intrusion band, I have what I want, as I told you and I showed you, but my coffee, just a little bit. to be awake. So I have the intrusion, which I want, but again, I'm applying the force outside the center of resistance. The line of action of the force is outside the center of resistance, and it is going to generate, and it is going to incorporate with the intrusion moment, or with the intrusion vector, a moment, in this case, a counterclockwise moment. So what can I do to avoid that? And most of the time, I don't want that to happen. I don't want that outcome. I want to control the intrusion, doing the intrusion without buccal inclination of the crown. Otherwise, I may end up with a crossbite in the second molar. So what can I do? What shall I do to avoid that? Well, I can apply another band for that. I can apply an inset band to control the out movement, to control the inclination, the buccal inclination of the crown. So for that, what can I do for that? An intrusive band plus an inset band, so or step in band. So we have those situations, intrusion band plus step in band. So what's going to happen biomechanically speaking when I do that? Well, we have this vector, which is the vertical vector, plus the horizontal vector. And we have the resultant here, which approximates, which makes the line of action of the force to be closer to the center of resistance of this tooth. Meaning, I will have the opportunity to control this buccal inclination using the opposite band to the moment, to the movement I'm generating, which is buccal. Do you agree with me? I'm going downwards and buccal inclination. I don't want the buccal inclination. I go inwards with a bend. You may ask now, maybe asking yourself, but what is the size of the band that I have to use to control that? No one knows. This is the truth. No one knows. It is visit by visit doing the control, seeing if it's okay. So you increase the band that is not applying the right force, that's not acting properly. For example, you do the intrusion and do the step in. The next visit of your patient, what you see is a buccal inclination. You don't increase the vertical, you increase just the inwards, the band, the inset band, and you do it again and again. Because it's not rocket science, guys. It's not rocket science, my friends. We do that step by step because it depends on the bone density, the bone level, the size of the roots, the size of the crown. So you have many variables that we can control. I can say to you, apply just 1.65 millimeters horizontal and 0.78 millimeters vertical. You may do a lot of articles to explain that, to study that, but we won't deal with the huge variability between human beings. So bad news, you have to do this step by step. We go, we control. We intrude, match inclination, we control the inclination, go inwards. This is what we do, okay? So I don't have this answer, this mathematical answer of the size of the band. I go always with slight bands, very light bands, very discrete bands, and I go increasing till I have the outcome that I want, okay? This is how I do. Just a second, guys. This time zone thing is very messy, you know, because as we are speaking to, as I told you before, we have almost 100 participants. They are not all here now because some of them asked me the opportunity about the opportunity to see this after, and we are recording this session here, and we'll allow you to see for 20 days, as I told you before, and many of these participants are not present now because of the time zone. But now I see that one of them is asking me when the lecture starts. Oh, wow, it's very difficult, I know, because all this mathematics that we have to do, plus GMT plus 3, GMT minus 4, it's messy, I know. Let's go. Let's move on. So in this case, 2 bands. As you can see here, we have this situation. This is a patient that underwent a surgery first protocol. So we didn't do the leveling and aligning before surgery. We have to do this after surgery. So when we did the mandibular advancement, we have this contact in the posterior region. If we did a regular preparation for orthognathic surgery, we would have did that before. We have aligned everything before, but this is something different. We do the surgery, then we do the orthodontics. This is what we call the surgery first protocol. So when we did this, the advancement of the mandible, we ended up with this situation here. So we had to deal with this. What to do now? An intrusion band and step in band plus an inset band. As you can see here, we have probably the third or fourth band. We do every time patient comes to the office, we increase the band and we control everything, the intrusion and the buccal inclination. So we go changing the bands accordingly. If we want more inclination, if we want more intrusion, we go step by step, okay? This is what we do. This is an extrusion band, and let me show you a clinical situation. And this clinical situation shows us why we need to understand how to deal with this band, how to practice with this band, how to do the bands. Because some people say, oh, it's enough for me to buy those pliers, those pre-activated pliers, preset pliers for that. But let's see, do we have a plier, enough amount, meaning magnitude of bands, and those pliers that we can do this kind of extrusion? Let's see, this is probably the 8th or 9th activation of this step here. We don't have these pliers, okay? So we need to do that manually. We need to do that by our own hands, okay? How we do that? Practicing, practicing, and practicing. That's it. That's the answer. That's not a magic trick to do that. Wow, I'm going to do it now and I'll be perfect at that. No, there's not. Unfortunately or fortunately, there's not. So we have to practice. We need to practice, okay? So in this case here, a patient came to us with this situation. He was, every time the crown fell off, he would bone again, bone with super bone, and do it again and again and again. And he ended up with the situation with a very bad position of the gingival margin. And after some time of periodontal treatment, preparation, we started doing this extrusion, low extrusion protocol. What do we do here? We do 0.5 millimeters each 15 days. 15 days, patient come back to our office, and you do it again, and you do it again, and you do it again, but not just downwards. Remember, I'm going to show it to you. Let's go to the video here. This is pre-treatment, and this is what we get, and this is the final outcome. So as you can see, the bone level followed the movement, which was expected to happen because it is a slow extrusion protocol. Do 0.5 millimeter each time patient come back to the office. Every 15 days he or she comes back to the office, and we do 0.5 millimeters. And we do the adjustment of the tip, of course, because we want to increase the level of the relationship between the bone insertion level and the leverage level. So the crown outside the bone and the bone inside, the root inside the bone. So as you can see here, after this extrusion protocol, we have a very good outcome. And you will have access to this article too. This is another article that I published some time ago with this protocol. So you will understand the protocol. I'm just highlighting here the possibility of doing that, understanding the need, understanding the protocol, and understanding how to do. Okay, so for that, you will have the videos that I'm gonna share with you. You will have the article that I'm gonna share it to you, with you, and you have to practice. Use your pliers, use your wires, take your time, break your TV. Don't see TV, just go on doing that in your daily routine, okay? So this is how we do. Another situation in which apply the same thinking, they need to do the extrusion, they need to do to understand the protocol, to understand the interrelationship between periodontics and orthodontics. This is a case of periodontal bone loss, and in this case, we did slow extrusion. We are going to extrude anterior teeth, slowly extrusion, in order to achieve a better bone height here, bone leveling in this part, because this is the part where we have the bone loss. And after that, we close the space, meaning I put lateral incisor in position of central incisor, canine substituted the lateral incisor, and premolar at the end of treatment ended up in the local of the canine. Okay, so this is something very unique. We don't do that often, but it's another possibility. And these cases are very interesting, because when you show this case in social media, people would say, wow, is it good? Is it really, why don't you just put the implant in position? Mainly implantologists, they say this. Why don't you just put the implant? Why so much work? Because if you put the implant in position, you wouldn't have corrected the bone level, first of all. Even if you put bone graft in here, is very difficult because of the defect. The nature of the defect, four walls nature of the defect, is very difficult to keep in position. Other than that, you have a class 2 here, canine, premolar class 2, so we have to deal with this, with the overjet also. You can both go forward, because you have half cusp class 2 here, or go backwards. So I don't see the point of going backwards, extracting premolars, and then having to put, after correcting the class 2 position of the canines, having to put in the anterior part of the arch 2 implants. Why not going forward? So this is my thinking here. Let's see the video. So as you can see here, the extrusion, same protocol, 0.5 millimeter each time, each 15 days, 0.5 millimeter, 0.5 millimeter, and it goes on and on and on. So adjusting, you have to avoid at all costs the contact between the upper extruded incisors against the other arch, against the lower incisor. If that happens during the extrusion, you may lose your teeth. So take care, take care. If you need to use bite planes for that, use it, but avoid at all costs the contact. You will lose your teeth. So here, just a biomechanic touch using the line of action, higher line of action of the force, extrusion, closing the space, extracting one incisor, closing the space, extracting the other incisor, closing the space with a higher line of action of the force. And here we have our friend Manuel, and it's the end of the treatment. Actually, we finished this case, and we also have this case published recently, and I'm gonna share it with you also, okay? This is very interesting, the possibility of doing the extrusion step by step, okay? Sometimes you don't need to do that much. sometimes we anticipate that just since the beginning. As I showed you at the beginning of our class, we can do the positioning of these bracts using this concept. As you can see, the gingival margin of central incisors the gingival margin are at the same level of the laterals and are lower than the canines, and lower even in comparison to this lateral incisor here. So since the beginning, we have planned to do the intrusion, because what we have here, of course, we don't have enough time to say everything about this relationship, periodontal or dentistry, cosmetic dentistry, but we have here this possibility of intruding the gingival margin, which would increase, which would be very beneficial. It will benefit this patient because of the rate between the height and the wideness, the width of this tooth here, those teeth here. So we have this distance, mesial distance here, almost the same as the height. What can we do in this case? We want to increase the vertical distance here. We want to increase the size, the vertical size of these teeth. And for that, we can either intrude and then we do this composite and the tip, or we can do the surgical correction here. But this patient had periodontal health, and so we didn't want to do osteotomy here, what we should have to do if we did this surgical procedure. So in this case, our option was the intrusion. Okay, let's move on. And so that what we did here, we put during the bonding, we did position the bonding, the central incisor more, the central incisor bracts more incisal, okay? So we intruded here a little bit. But at this point I thought, no, it's not enough. It's not enough. I want to go a little bit higher with this gingival margin, and I want to make a lot more space to do this composite and the incisal tip. So what can we do in this situation? Intrusion step, okay? So if we don't consider this enough, we can do intrusion step. And here we have the incisor being intruded. And now we have this situation. Of course, we have to talk everything before with the patient. Patient has to understand that is going to happen and have to be part of the treatment, because if not, he will say, well, it's got something odd here. I don't like this kind of step, this negative step here that you're showing me. So you have to do everything with your patient. You have to control everything before you do. And in this case, after that, we did the cosmetic dentistry at the end of the treatment. And now we have the situation. The gingival margins now are corrected, and we have now a better relationship between the height and the wideness of this tooth, okay, this both teeth. So this a composition between the bonding, more incisal positioning of the bract, plus the intrusive step, the intrusion step, okay? Good, and now we go. And just for you to see, and just for you to remember, we need to do, when you do intrusion or extrusion, and we don't want to have a moment generating during that movement, we need to incorporate another kind of band. So in this case here, extrusion band, we don't want to have this moment because it would jeopardize the incisor, put in contact the incisal edges of the upper and lower incisors. It would be disastrous, so we don't want that to happen. And we want the incisor to go this way. As I told you before, this article is going to be shared with you, and you see step by step how to do, just calling your attention for that situation. As you can see here, guys, as you can see, we have it here, this step out band. Not just step down, but also a step out band to counteract the tendency of the moment to incline the crown palatally. So this is how we do, okay? Let's see it again. Let's see it again. Let's just for you to see. As you can see, all the time you have to have this clearance here. Don't let this crown contact the opposite arch. Please don't do that. It will be disastrous, okay? All the time you have to check. All the time you have to do this. And if you have a rectangular arch wire, it would be easier for you to control the moment. But with rectangular arch wires, you got to remember that this is a stiff arch wire. So you may have a very, very stiff band, a very, very difficult band to manage. So sometimes we do that with rectangular arch wires, but this is something that we have to keep in mind. This is a very stiff arch wire. So if you want to do that very slowly, if you want to do in a more controllable manner, we need to do that with thinner arch wires. But this is a possibility, definitely a possibility, and it gives us more control. But the arch wire is too heavy, the force may be too heavy for that. So just this, I have to call your attention, okay?